like everybody to sit down. Delighted to have Dr. Chris Coetzee here today for the foot and ankle team's visiting professor. Dr. Coetzee, as you may have looked at his CV, started in the way south of the planet in South Africa and went to the best medical school there, was the star resident. And one of the great things about the United States is we attract incredible talent. And his journey here was not direct. He had to go to the way north, to northern Canada, and then eventually came down a little bit to Minneapolis. On the way, during his journey, he stopped in Seattle and did a year of training in foot and ankle with Ted Hansen, who was a superstar in our field and a real creator of a language and a vision of how to do foot and ankle care, and was a co-resident, was the Lazy Spine co-fellow, Lazy Spine fellow, Dr. Brown. Here. Anyway, superstars, both of them. He eventually, after going back to Canada, came to Minneapolis, spent 5 years on the academic pathway, and then took the boards, American boards. Not easy to do 10 years or 15 years after you get out of residency, or a number of years you have to know everything and pass part one, pass part two, and then stayed in Minneapolis since. He was first at the university and then went into this large group here where he has been continuously productive. He's been one of the major influences in the field and has shown that you can be a leader in the field, especially in foot and ankle, in private practice, doing outstanding research. In the last decade or so, he's become very involved with care of athletes.
Recording in progress.
And many other professional athletes from around the country that fly in to see him. And his first talk today is on that. I wanted to just impart one last story, personal story, which was Pat Luter used to be the foot and ankle surgeon in Minneapolis. He's gone now. He was known as the person who runners would come and see from all over the world, actually. And when I was young, I used to go to the meetings and teach. I began to teach at some of the courses, and Hap was always teaching. He and I and one other guy used to go, it's hard to believe, he used to go and jog between things. And we went all over, we got into all kinds of bad places and cities and stuff. And he usually would say, Iowa City's nice, but you should come to Minneapolis. And then one year he said to me, Iowa City's nice, but we don't need you in Minneapolis. We got this incredible guy coming. He's going to be much better than you. That's Chris Kelly.
I don't think that's true at all. But it's interesting just talking about the boards. There are some advantages of doing your boards after being in practice for 10 years, because I only did foot and ankle. And the boards is obviously about your practice. So it was not, the oral part was not the hardest event. The written was not that easy. And one of my examiners from North Dakota actually brought a case to the exam. And as you know, I know you know what you're doing, but I need help with this case. But can we go through my case? So that was pretty fun. So it's interesting with grand rounds always to think about what to talk about. And because I know you see very complicated stuff at the tertiary center. So I decided not to go the ankle replacement route that I often go, because it's kind of boring in a way. And I want to talk about bread and butter orthopedics. If you go into a practice, this is the stuff that you will see often. And I always say this is the low-hanging fruit. If you do this well, that's how you develop a practice. So you want to deal with injuries well, especially high school athletes, because high school parents talk a lot. So if you first time you treat Johnny with a fifth metatarsal fracture and he goes back to play, the team will come to you. So let's start with exactly that. if you think about in-season injuries, the question always is what can go back to play and what is when there's a season-ending injury. And season-ending is a less frank that needs surgery, Achilles ruptures, a turf toe that needs surgery, and then we had a great case yesterday about a deltoid injury. Those are season-ending, but the Jones fracture, lat ligament, simple ankle fractures and some syndesmosis injuries are not season-ending injuries if you treat them well, obviously depending upon where you are in the season. If you think about a Jones fracture, first question is, do you treat it surgically? Because there's reasonable evidence that if you leave them long enough, it will probably heal. But I can tell you now, if you live in a small town and you let them be non-weight bearing for 6 weeks or 8 weeks, and then they go back and they fracture again, that's not a good thing. And that's personal bias. I don't think the mechanism of stress fracture of the fifth metatarsal doesn't go away. So even if they heal and they go back and do the same thing, there's definite risk of having a stress fracture again. So I treat fifth metatarsal fractures, and there are obviously good evidence to show that if you treat them surgically, they can play. This paper talked about 25 players with open reductions, and then iron screw, and then iliac rest bone marrow aspirate, and a bone stimulator, and all of them returned within 8 to 10 weeks. But because they returned relatively quickly, there was a 12% refracture, even with the screw. That's the one concern that we have with fractures. You can imagine if they refracture with a screw, a much higher percentage would have refractured without a screw. And now Jones fractures are fairly popular, so all the companies are living up to the Joneses, and there are multiple different screws, and you need to look at the screw design and all the mechanics around that to decide which screw you prefer. I don't have a preference. I use whatever they have in the surgery center. But there are technical issues. And this is where it becomes important because it is such an easy operation until it's not easy. So your starting point obviously has to be correct. And most of the systems now have a cannulated roll system with a solid screw. And the idea is that it makes it a little bit easier to find the spot. But unfortunately, a lot of these have a fairly sclerotic cortex, especially the plantar lateral cortex, because most of them are not acute injuries. It's acute on chronic. So this thing has been brewing for a while, so it's making extra bone formation. And not infrequently, you will see that fairly thick sclerotic tissue. And so if you now try to get a guide wire in there, there's a definite risk of the guide wire not finding the path because that sclerotic margin pushes it off. And this is an example of that. And luckily, the surgeon was kind enough to share his entire X-ray file with me, and you can see he's trying to get the guide wire in and cannot get it in, and then eventually ended up with that. Now, the issue with this is it broke through you can see the guide wire broke as well, and then the screw went through the medial side, so that entire piece is loose. So when I saw this patient, the dad said that this was a high school wide receiver, and so, you know, the surgeon said it's going to take 15 minutes, and 2.5 hours later he came out and said he needs to be in a cast and non-weight bearing for 8 weeks, and if there's any way around that. You can maybe say that the entry point was not correct, but this was purely because of that sclerotic margin trying to get through with the guide wire. So the salvage for that is, I think it's okay to use a guide wire just to make sure that your entry point is good, and then you can maybe just drill 5 millimeters, but I always drill with a 4.5 millimeter drill down to the fracture, because that way you can ream out that sclerotic cortex and get your your screw then in the correct position. So this is the same case. You can see that little piece of guide wire that's still in the shaft, and just by reaming out the sclerotic margin, you can get past that piece, and then it heals and it's fine. So this is interesting also thinking about people that work with you. Chris Larson is one of the best known hip scopers in the country. People fly from all over to see him, but he was the orthopedic resident in North Carolina, and he's one of my partners, and this is probably his paper that gets quoted more than any of his hip papers, and he has not seen a foot fracture in a very long time. But in any case, he had this really good study to show that you should not use cannulated screws for fifth metatarsal because about 40% of them fail. And especially if elite athletes, so cannulated screws fail, and it's a piece to get out if that screw fractures. So this is one of these examples. So, but what about refracture? So this is one that I did. He was an NFL player. 7 weeks later, everything looks great. And so the question is then, when do you return to play? And I do a CT scan on all of them to see if it's healed before they return to play, because it is somewhat controversial if you should let them go back at 6 weeks or 7 weeks or 8 weeks. But on the CT scan, he was completely healed. So returned to play and everything was fine until almost exactly a year later, he came off the field and felt a pop. So of course we did a CT and it's refractured with the screw in place. So the question is, what do you do now? Do you go the more conservative route of immobilization? Do you use or bone stimulator, revision screw, or plantar plate? And it was interesting, this was around the time where there was a little bit of research about plantar plate versus intramedullary screw. And this is Dr. Warner from Houston that did the study, 12 pairs. He showed, okay, so the plantar plate allowed for greater cycles to failure, greater peak load to failure, and less gapping with load. And they also had a follow-up study where they had 4 refractures with primary fractures treated with a plantar plate, and minimum 2-year follow-up, and they had no non-unions or refractures. So then the question becomes, do you treat these routinely with a plantar plate as primary procedure, or do you still use an intramedullary screw? And I don't think the jury is out yet, because the intramedullary screw is so simple. So I still do that as a primary procedure, but we'll have to see how many of these fail in the end, and then you might have to switch to plantar plate alone. This was also Bob Anderson's group that treated all of their refractures and non-unions with the second screw and bone graft, and they all returned to play, but they had 1 refracture again. But to get 20 out of 21 to heal is not too bad. But I then elected for this guy to use a plantar plate. That was the first one that I did, and it turned out perfectly fine, and he returned to play the same season. The issue is again to remove the screw. That's really sometimes very difficult. You can see with this one how much I had to burr out of the base of the first metatarsal just to get to the head of the screw, because the head was countersunk too much, I think, and it leaves you with a fairly abnormal looking keyboard fifth metatarsal joint. This is one that I saw recently. I didn't do his primary surgery, but it healed very well and no issues. And then about 6 months later, or 4 months later, he fractured. And then he was treated at the local facility where he was done initially with BMAC and all that. And it's been about 3 months and it still didn't heal. And interestingly enough, if you look at these 8D X-ray, you can also see that the entry point is a little close to the keyboard. It caused quite a bit of irritation in the keyboard. So he said during that few months that he played, he always had lateral ankle pain or lateral foot pain. So the plan was after the season to, in any case, remove the screw. But he had the refracture. that was pretty interesting to get that screw out as well. But then eventually got it out with that little defect in the cuboid, which will heal because it's not really in the articular surface area. And then did the plantar plate, and the plate's on the tension side, so you know it should heal. Most of them will heal, but now he's doing fine. Saw him just a week ago, and he's already back starting his rehab and will hopefully play pretty soon. On exactly the same day that I saw him back for his 6-week visit, I saw a guy from North Carolina that initially healed fine, same thing, started to play. You can see with the x-ray in September on the left, there's a clear fracture again. So he had BMAC as well, and it was interesting. If you look at this x-ray, I'm not sure what happened, but most of the BMAC went distal to the fracture. I don't know if that was part of the reason why it didn't heal, but I don't think the BMAC after the fact is a great idea. I think you need to open the fracture and make it raw again. So he's on the schedule now to be done next week. So my approach to a Jonas, I do surgery on all of them, irrespective of the age. If you have a stress fracture, then it needs to be fixed. And cast them for 2 weeks, partial weight bearing, and then they go into a cam boot, weight bearing is tolerated. They start their rehab 2 weeks after surgery. Ideal is to be in a pool, but you have to have the facilities to do that, and we are lucky enough to do that. So either a pool or an Alter G, and then at 6 weeks they can progress through activities as tolerated if the x-rays are good. And usually by 6 weeks we do a CT scan, and depending upon the sport, if they're ready to play, they can play somewhere between 6 and 8 weeks. Any questions about Jones fractures? Okay, so the next is Achilles ruptures, and same thing, repair or not repair, because we all know the studies that came out of Canada that show that people do exceptionally well with non-surgical care. And it was interesting at the Foot Society meeting in Quebec last year. There was Dr. Cadler from England that basically said that these, in his very nice English accent, said it's bullshit, which I'm not sure which is true, but there's definitely a big school of people that will treat the Achilles ruptures non-surgically. And lots of papers now that promote that. But I challenge you to show me one professional or non-professional athlete that went back to play after non-surgical care of an Achilles tendon. I really, do you know of anybody that went back to play?
No, but I think in the country, only about a third are being treated operatively. If you look at large databases, so it's interesting, right? But that's all comers, not athletes.
But it's also interesting with our rehab facility that we have at Twin Cities, we are looking now, we are actually recruiting people that were treated non-surgically, because I treat all of them surgically. And then we want to take them through a short rehab program and then test them and see what the strength differential is between the surgical ones and the non-surgical ones. Because I hope that it shows that the surgical ones do better, because I strongly believe they do better. So I do them supine, cast for 2 weeks, boot for 4 weeks, and then they start the rehab. And maybe it's the same with non-surgical. The surgery is just part of it. You need to make sure that you get really good tension on it and with a good suture construct. But after that, the return to the level of play depends upon the rehabilitation. So every patient that we see get this, it's a little, almost like a booklet that they get to show them where they should be at whatever interval. And they know they need to come for the rehab on a regular basis and follow the protocol, because the big thing with an Achilles rupture, these people are usually in peak shape, unless if it's people like me that play pickleball and rupture the tendon. But most are young athletes, they are in very good shape, and now you tell them you're not going to play sports for 6 to 9 months. So it's a lot of it is the psychological part of recovery, and you need to show them that they are right where they should be at every interval so that they don't lose faith and excitement about their recovery. We use a very specific program that's quite intensive. They stay there 3 times a week for about an hour and a half going through the progression, and then so it's focused rehab, and then the return to play depends on very specific objective measurements. So they look at the heel raise and calf strength and all that, and you can look at this. So there's a full set of tests that we use, how many times they can do the lifting, and initially they do it with electrical stimulation. And then this was a CrossFit girl, and she ruptured it when she did the box jump. And I get these texts from the therapist on a fairly regular basis about how they're doing. And this was her at 12 months. So I don't think it's smart to do box jumps like that, but that's what you do in CrossFit. And she's absolutely completely back to normal. Same with this NFL guy. And so once we test them and we know they are 90% strength compared to the opposite side, then they can return to play. We talked about this yesterday a little bit as well, so I'll go through this reasonably quickly because it sounds like you guys know more about this, Frank, than what I do, which is good and not difficult. But it's obviously a wide spectrum of injuries, and injuries that you see as a sports doc will be different than the injuries that you see as a trauma doc, because the mechanism is different. A lot of the sports Lisfranc injuries are plantar flexion injuries, while almost all of the motor vehicle will be dorsiflexion injuries because you slam your foot against a brake or something and you rupture plantar first. Well, the sports injuries are oftentimes dorsal first, and they are not as unstable as the motor vehicle accidents. Obviously, we published this paper about high energy injuries, and this was all motor vehicle, or most of them were motor vehicle. But if you think about the Lisfranc, it's really good to look at this paper because the Lisfranc complex is a lot more complex than what we think. It's not a single ligament. Even the ligament between the medial cuneiform and the second metatarsal is not one ligament. Most of us will have 3 parts to a dorsal, plantar, and middle, with the middle the strongest. Some people don't. Some people have a single one, and those are the people that are more prone to Lisfranc injuries. And obviously you don't have an MRI of all the people before they injure, but that's why you need an MRI to see what the structures they are and what is all injured. And you can see there are the different bands to it. And what I think is correct, the stronger the plantar part of your Lisfranc ligament is, the lower the chance that you will have a Lisfranc injury. This is also interesting. Another good paper talking about instability patterns. So to get a transverse instability, your Lisfranc ligament should be cut, as well as the plantar ligaments between first metatarsal, second and third metatarsal, as well as first cuneiform. To get a longitudinal instability, it's just Lisfranc as well as the interosseous ligament between C1 and C2. And we actually looked at a case like that yesterday. That's a sports injury. I don't think I've ever seen a longitudinal Lisfranc in a trauma case, but it's usually if you push off on your first metatarsal alone, so it's usually in a cutting movement. So you try to change direction quickly, and all your weight goes on your first metatarsal, and that then transfers the force between the first and the second ray And this is the injury that we see a lot more common now on artificial turf. I think most of the Lisfranc injuries will be this longitudinal variant. And also manual stress x-rays show greater displacement than weight-bearing x-rays. We talked about that last night as well. I personally, every single Lisfranc injury will test them under fluoroscopy to see if there's instability and what the instability pattern is. I think you should talk about the Lisfranc joint complex and not the joint. There's much more stuff going on in a single ligament, all the skeletal elements and the ligaments as well. And we know that broad classification is low energy versus high energy. With stage 1 is if there's less than 2 millimeters diastasis on the weight-bearing X-ray, but again, that could be very subtle and it's good to test them. And with stage 3 is if the medial longitudinal arch is collapsed. So this is by Nandi and Bertullo stage 1. They can weight bear, but not return on the same day. They point tender, weight-bearing X-rays show no or minimal displacement and no collapse of the medial arch, but that little bit of displacement. The lateral X-ray is the most important. There's no displacement at the first tarsal joint. Stage 2, similar findings, but a little bit more displacement. And stage 3 is where there's significant displacement, but most important on the lateral view, there's collapse through the tarsal joint. I don't think you can determine the stage I don't think you cannot determine the stage just by X-ray. You have to do additional testing, and the best test for this is still an MRI. Stress tests are very helpful. I use stress tests to determine if it's something that needs surgery or can be treated non-surgically. CT scan helps to see your construct in 3D and see if there's fractures. So for trauma cases, you will do a CT scan more often than in sports injuries. Hopefully this will play. Let's see if I can get video to play. It's okay. The stage 1 plantar ligaments are intact. It's a partial injury. Lisfranc complex is stable. And we treat them symptomatically. So you need compression sleeve for a while and a custom orthotic hard-soled shoe, and most of them can return to play pretty quickly. In stage 2, those are the ones that you need to take a very close look. Best to examine them under fluoro, where it's under anesthetic or not. If it's stable, you treat them like a stage 1. You just know it's going to take longer to heal. If it's unstable, they need fixation. And that's a typical longitudinal instability. If you put a freer in there, you can see that it opens pretty wide. Stage 3 is, you can see that that's unstable. There's no way that you can treat that non-surgically. And return to play stage 1, orthotics, tape, return to play is tolerated, and it can take a week and it can take a month or anywhere in between. Stage 2, orthotics, tape, return to play is definitely delayed compared to a stage 1 because they are much more painful and you don't want to aggravate the injury. Stage 3, they are obviously treated surgically and then heel touch weight bearing for 6 weeks. I'm not a big fan of non-weight bearing. I don't think there's any surgery that I do now for foot and ankle where the patient is non-weight bearing afterwards. I think if you think about bone physiology, bone wants load to heal. Same with ligaments, they need load to heal. So if you have a good construct with your surgery, I don't think there's any downside in letting them at least be touch weight bearing, if not partial weight bearing. The rehab for this is slow. You start, I didn't start before about 9 weeks. And I do not remove the screws before 4 months. So this was a very unique injury. You can see it longitudinal, but the force also went through the medial cuneiform navicular joint, which was not unusual, but just a more severe deformity. but I don't like to fix the naviculocuneiform joint. I don't know if I'm right or wrong, but I usually just put screws through the metatarsal and the intercuneiform area, and you can see that one screw is backing out a little bit, but this healed very nicely, and then usually at 6 months, take it out, and the naviculocuneiform joint reduced well, and it does not look like there's any instability there. This is one where you can see on the right-hand side that there's also a little bit of displacement right there. You know that's a little bit more complex injury than the usual longitudinal ones that I see. And then in the fluoro, it definitely opens at the second tarsal joint as well. And with those, you bridge plate, and the bridge plate construct depends upon where the major instability is. The major instability is first tarsal joint, that's a joint that I will bridge. If it's a second MTP joint, then you bridge that one, but you still need to use your less frank screw. If both are very unstable, then you put a bridge plate over both. And I know most of us now use bridge plates instead of transarticular screws, but I don't know if there's good research to show that it's that much better. But I think if you think about breakage of screws, if you break a screw in this situation, there's no harm. If you go transarticular and you break a screw, then theoretically you can cause damage with that deeper part of the screw that's still there. I think it's important when you remove the screw, the plate and screws, to test them again. And we saw that case yesterday that was painful before, and I usually feel if the pain doesn't go away very quickly after you remove the hardware, it probably means that joint is still unstable. So you have to go into the OR with a consent that says if it's unstable when I take the plate and screws out, that you will fuse the joint. It doesn't happen often, but occasionally it does. But this was again a typical longitudinal less frank injury. You can see it's fairly unstable when you test it. And with this, let's see if it shows that. You can see I'm testing the first tarsal joint, and the joint capsule was not injured at all. But then if you go into the less frank space, that's clearly unstable. This is just the flip side of it. In my hands, you can never treat this without a fusion. That's just not going to work well. And this is how I initially convinced myself that I'm doing the right thing. If you think about it's logic versus emotion. Our emotional response is that you should not fuse a joint. That's been taught for decades and decades. But if you think about a hip, the hip is inherently stable. So if you reduce a hip dislocation and they don't get AVN, they're going to be fine because there's a deep socket and you might have a labrum injury that you might need to deal with, but it's stable. Your less frank joints, the tarsal joints, are completely flat joints. Next time that you do a dissection there, look at the joints. They are flat joints, so all the stability depends upon the ligamentous structures. So if every ligament is torn, it's hard to believe that your scar tissue is going to create enough stability over the long run to keep the joint congruent and completely stable. Yeah, that's just my 2 cents about it. So post-operative care, PT starts at 6 weeks, then they do the normal rehab, and after 3 months they go to a molded shoe and insert, and the recovery to play takes long. I usually don't advise my less frank patients to try and play before 6 months. There's some evidence, or there's good evidence that people with less frank injuries can return to play. This was a study out of England that shows that these people can return to play, but they also say if it's a really severe injury, it might be better with the primary fusion. Another one, 17 players, they all returned to play. These were all open reductions, and they've removed them in 6 weeks. get to the one study that I think is actually helpful. So they basically concluded that competitive elite athletes can return to play even with a Lisfranc injury. Another one that basically shows the same 93% return to play. But this is where I think the problem is between open reduction and fusion, because I think outcomes measures are very important, and we need to do studies about this. But it's difficult to compare because we don't have the preoperative level of function for these Lisfranc injuries. So this was a study by Cochrane in San Diego, out of a military personnel study. 32 patients, 14 primary arthrodesis, 18 open reduction, and with the outcome scores, the return to military duties and fitness test score. And this is the unique thing about the study. These were military recruits, so they had to do the fitness tests when they get in, and they do it every year. So they have a pre-injury parameter that we don't have with the other people with a Lisfranc injury. So return to full activity for primary arthrodesis was 4.5 months, with open reduction 6.7 months. Fitness test, this is really, I think, fascinating. So arthrodesis, they were a year later, 9 seconds per mile slower than before the surgery. Open reduction group, 39 seconds slower. So you cannot say, well, maybe the one guy was fat and the other guy was skinny. This is against their own parameter from a year ago. So the simple thing is, if you on safari in Africa, you hope that there's a guy with an open reduction and you have a fusion because you will not get eaten. But interesting, if you look at the outcome scores, it's exactly equal. So if you, the paperwork they filled in looked like the open reduction group did exactly the same as the fusion group, but not the physical testing. So they concluded that the fusion group was better than the open reduction group. So I think you should treat everyone individually. This is not a cookie cutter business. I cannot tell you how to treat every Lisfranc injury. You need to look at it and decide what is best in that specific situation. And if it's partial instabilities, you can do an open reduction. If it's a severe injury, I still think it's better to fuse them. Yeah, I think we have a little bit of time. Let's go through this quickly. So, because this you will see, this is, as you know, the most common athletic injury in sports is lateral ligament injuries. And the question is, how do you deal with this? And especially as a sports orthopedic surgeon, how do you approach that patient that come into your office and say, well, I have a grade 3 ligament injury, fix me so I can play quickly. And this is where you really need to go back to basics. This is a great study out of Finland where they looked at surgical versus functional treatment for acute ruptures of the lateral ligament complex in young men. Also a military study. The good thing with those, the patients cannot go anywhere, so it's easy to follow them. And it was a randomized control study, all grade 3 players, so they did MRIs on all of them, so we know they were a grade 3, so you can compare apples to apples. And the surgical ones had repair within the first week, and then below the knee cast for 6 weeks, full weight bearing and functional rehab after 6 weeks. Well, the functional treatment, air cast brace for 3 weeks, full weight bearing, starts rehabilitation at 3 weeks. And then basically the same rehabilitation program, and they followed them at 3-month intervals up to 1 year, and then yearly for 14 years, which is pretty unique for any study. Equal long-term follow-up. There was a slightly higher re-injury rate in the non-surgical group, but a significantly higher arthritis risk in the acutely repaired group. And they don't know why. So the question is, did they make it too tight, or was the manipulation of the joint, that something happened? So the takeaway from that message is, even in 2023, if you have a young athlete with a grade 3 injury, you treat them non-surgically, because more than 90% of them will be fine. And you treat the 10% that develop a chronic instability surgically, because there's such an emphasis on doing surgery on everybody that walks into your office that we will do a boatload of unnecessary surgeries. I know there's a fairly strong push now for micro instability of the calcaneum keyboard. My advice to young people is just beware of things that are not true. And that's one of those things, because calcaneum keyboard instability might be true, but it's not every second patient that will walk into your office. If you do surgery on those and put an internal brace or something in there, that's my mind malpractice. So there would, another one where they again show that non-surgical treatment for lateral ligament injuries should still be the mainstay. Important, it's like any injury, it's the rehab, it's not the initial treatment, because I see a lot of old people that had chronic instabilities that now need an ankle replacement because their wheel balance has been off for a long time and they wore out their tires uneven. So non-surgical does not mean no treatment. Non-surgical means non-surgical treatment. So again, we hand out these cards because people like visual reinforcement of where they should be, and show them exactly what they're going to do and where they should be at every interval. And you can also see at 3 months, if you look at their rehab and test them again, if they're doing well. And the ones that are 3 months out or 6 months out and it's clearly unstable, you say, okay, we made a mistake, we should have done your surgery. And then you do the surgery and there's no harm done and no bridges burned. But then if you think about the repair, rostrum is still the gold standard, and the goal is to get them back to play without compromising short or long-term results. This is a study out of Vail by Tom Clanton and his group that shows that compared to your native ATFL, the rostrum is about 50% the strength. And it does not matter how you do the rostrum, whether it's pants over vest or with 1 anchor or 5 anchors, it's the quality of the tissue is never as good as the native ligament. So if you say, and I was one of those that say my rostrum repair is as strong as it needs to be, that is just not true. There's studies that shows that rostrum with or without anchors is significantly weaker, 50% weaker than the native ligament. So you have to protect the repair to avoid premature failure. So if you do a standard rostrum without augmentation, the return to play is somewhere between 4 and 6 months safely, because that's how long it takes for tissue to mature. You cannot cheat biology. You can put 5 anchors in, the ligament still needs to heal and become organized tissue. Other thing is, you're confident I can move my rostrum early. And this is a study by Lucian and his group that showed unprotected motion was associated with significant lengthening consistent with failure of the rostrum, irrespective of the way to treat it, whether it's with anchors or without anchors. And all my rostrums do well. Again, this is a study that shows that 26% of this study patients stopped doing their athletic activity because they didn't feel stable. And 16% had to decrease their activity. So if you look at your patients closely, you realize that they are not doing as well as what you think they are. Other thing is, well, it's just immobilized them longer, but we know that with collagen healing, if it's suspended, the tissue there is abnormal. So when you then start to move, then it takes a long time for the tissue to organize and become somewhat functional tissue. We know the effects of immobilization. You get atrophy and osteoporosis and all kinds of bad stuff that happens. So how do we improve the standard rostrum? And this was again done by the group in Vail quite a while ago, where they say if you augment it with suture tape fixation, then you can increase the strength significantly. And I said it last night as well. I'm not here to promote a specific device. I use whichever device they have in the OR, but I really think if you do this correctly, you can get your patients back a lot quicker. And when I started to do augmentation, I see there are a few people here that are my age or a bit older. Just when I started orthopedic residency was the final year or two of Gore-Tex cruciate ligament replacements. And that was the best thing that ever happened in orthopedics. It changed the world until it didn't. Because it's intra-articular, it's not anatomic, and it's not normal tissue. And they all failed. I see you are smiling about that, and I'm sure you remember those days. So you cannot use foreign material to be the ligament. You still need to do the ligament repair, and this should be outside the ligament, not intra-articular. So with the internal brace, it basically means that we can do the rehab a lot quicker. We start rehab at 4 weeks instead of 8 weeks, and we can push them very quickly. There are a few studies. This is one out of Korea, and then we did a multi-center study that basically shows the same. Well, a lot of patients in the study, and we did, I think, very good testing of the patients with stability and activity. And this was the funnest test to do, the single leg jump test, because you can see at every interval how they improve. And it's not only how far they can jump compared to the opposite side, but also mainly if they can hold the landing, because that is when you get your proprioception back. And that is part of the testing that we do to see when they can return to play, is once their proprioception is equal to the opposite side. And in our study, 88% of them were normal or near normal with the hop test. And interesting enough, and I think that's with most injuries, they almost never get back to 100%. You obviously have a subset of people that get back to 100%. But on average, if you have a good result, you get about 90%. So if we compare the current level to the preoperative, it's about 90%. And that we know at that level, they can safely return to play. Average was 84 days, and it was 180 was the longest. And this is like the beauty and the curse of a well-done study, where you don't exclude your outliers, because it makes it look much better if you take that 180-day one out. But that's part of the study, so that's just real life. And this was a ballerina that was at the end of her career, and she really didn't want to go back to her career. She wanted to teach, but we had to keep her in until she could return to that level of activity. But as a whole, the ballerinas take the longest, just because there's so much force in the occupation that they do. To go from plie to standing on point and do the jumps in between is, you need an amazing amount of strength and proprioception. And like with anything, there's in sports, there's some level of psychology that you need to deal with. So it's good to take a class in psychology before you do sports medicine. With another prospective randomized study that basically showed the same thing. So this is a short video. I will just show you how I do it, and it's not necessarily the way that you should do it. So obviously when you get there, it's not an acute rupture, so there's a lot of scar tissue there. And I always say, if you open the ankle at this point and you see the anterior talofibular ligament, you're either at the wrong ankle or the wrong surgery, or you didn't examine the patient before, because you don't see the ligament. It's just a lot of scar. So you see those, oftentimes it's a nice one like this, where both sides of your incision have thick scar, and that makes for a really nice brostrom that you can do. Sometimes it's very flimsy and there's about no tissue. I always want to see the peroneal tendons, because we know in these chronic ruptures there can be peroneal pathology as well. So I'm finding the spot for the first anchor. And again, when you do, next time that you do a cadaver ankle, make sure that you see where the anterior talofibular ligament attaches. This is the equivalent of doing a cruciate ligament in a knee. Your entry point or your anchor point should be at the footprint of your anterior talofibular ligament, in the fibula and in the talus, because that's the anatomic position, and that's where you know your function will be the closest to normal. just like with the cruciate, if it's not at the footprint, the function of the knee is abnormal. I put that anchor in first. Let me see if I can fast forward this a little bit so we know it's in the bone and it's good. You can do that under fluoroscopy as well if you want to. I did the first few under fluoro, so I know I'm not in the fibula or the ankle joint. And then the ankle at neutral. I don't really evert it, it's just at neutral, and then put the anchor in and get it at the correct tension. And once that is done, then I repair my brostrom, because I know what the tension is. I don't put extra anchors in for the brostrom because I don't think it makes any difference, and you might run out of real estate in the fibula. But then you do standard pants over vest brostrom. You can see how I can bring that entire flap over and suture it into the proximal part. Just one way to do it.
You don't separate out, you don't do the gold.
No, because I have the brace on top of it. So this is, I did this guy both ankles on the same day. He was on his way to the NFL and said, I cannot do it twice. So this is 14 weeks out. This guy is a soccer player, 12 weeks out. And even if you have special genetics, like a lot of these people do, you cannot do this with the standard brostrom. It's just impossible. That won't just not work. This is a soccer player. And this was all interesting because with the standard brostrom, the biggest issue is if you're a soccer player is when you kick. The vibration of kicking causes a lot of ankle pain while the ligament matures. While with these, we know that we can let them kick and they don't get that vibration pain from kicking. So I think you should protect your brostrom. It definitely adds strength to it, and it improves your stability and proprioception. And you can have an accelerated return to work and play. Okay, we'll stop there.
Yes, I have a question. I'd like to start. When I actually came here as a fellow and was at a conference here, and Trevor Holman heard a talk, and he mentioned sports magic. That's what he called it, sports magic. But I didn't hear anything about PRP, not much about BMAC. I didn't hear allograft, dermal allograft. I didn't hear anything about PTH agonists or any of that stuff. So what's your view on most of that? PRP is very commonly used. BMAC's always put into some of the surgeons that you trade patients with put BMAC in every patient regardless of what the diagnosis is or what it is.
Well, again, you should take my opinion with a salt, because I'm a bit cynical about that stuff. I think PRP is a wonderful way to have a cash practice. I did PRP for a little bit until I realized it makes no difference. I think it's a psychological. We don't realize how powerful psychology is, and the value of talking to patients and tell them this is going to cost you $1,000 and you're going to feel 100 times better, and then they believe it because they just lost $1,000 until it's a few weeks later and they don't feel any better. So you need to, and again, there are smart people looking at this. I think BMAC is okay, but you have to think about, let's say PRP for an ankle joint, for ligament. When I grew up as a resident, we say if you have a blood effusion in the joint, get the blood out of there because it's bad for the joint. Now we inject it with blood and we say it's good for the joint. It's hard for me to understand that. The same if you have a muscle tear, you inevitably develop a clot in the muscle, and it takes a long time to get it out. Now we inject the clot into it. So again, I might be wrong, but I'm not. I don't do any of it. It's the same using some foreign material around the Achilles tendon repair, I still, and again, maybe I'm wrong, but I don't think I'm wrong. Why would you put some dead tissue from an animal or an embryo around an Achilles tendon and think it's going to help you? Just do the surgery well and don't mess up the soft tissue. It's about soft tissue management. It's not about what you put around it. Yes.
Do you think that some of the studies comparing arthrodesis to ORIF in the list frame are limited by the fact that in the ORIF group, people are frequently placing transarticular screws? It's unclear in most of those publications when or if the screws are being removed, and if the patients end up with a little spot weld where the screw goes across. So what they actually end up with is a partial or incomplete arthrodesis that's painful for them.
Yeah, that's a good question. And I honestly don't think when you do an open reduction, you should put transarticular screws. You should use a bridge plate. But you know, I've said that many times, if you do an open reduction and you don't remove the hardware, it's still fused. You're just a closet fuser. You're not an open fuser. But, so if you of that ilk to only do open reduction, then you have to take it out. Otherwise, you fuse them. So. Yes.
So some of your mentors have advocated gastroc recession in the treatment of a lot of things. Didn't hear this from you today. So some people would say, oh, you got a cavus foot and a less frank, you should be doing a gastroc. Where do you land on all that?
You should do a gastroc lengthening if somebody really, really needs a gastroc. And in my mind, about the only place where people really, really need a gastroc is if you're a diabetic and you have a long-standing equinus contracture. I think it's totally wrong to do a gastroc for an athlete because it depends upon the situation. It can be 10% up to 40% of the push-off strength away with a gastroc. Unless if you do maybe a proximal gastroc, but if you do an old-fashioned stereo, it's, yeah, so the short answer is I think it's wrong. It's one of those things that are done way too often for questionable reasons. I've never done a gastroc for a less frank and they still heal. So I don't know. The less frank didn't happen because of the tight gastroc.
Well, thank you very much.
Thank you.